and the posterior superior aspect of the calcaneus, so the retrocalcaneal recess. And here we have a painful swelling superior to the calcaneus. In superficial calcaneal bursitis, this concerns the bursa located between the calcaneal prominence or the Achilles tendon and the skin. And here the symptoms are that there is a visible, painful and solid swelling of the posterolateral calcaneus, often associated with shoes with a rigid posterior portion. Then in the non-insertional Achilles tendon disorders, for the mid-portion Achilles tendinopathy, this is located at 2 to 7 centimeters from the insertion onto the calcaneus, and there is a combination of pain, swelling, and impaired performance. And then in the paratendinopathy, either acute or chronic, this is located around the mid-portion Achilles tendon, and in acute cases we will have edema and hyperemia, and in the chronic cases we will have exercise-induced pain. So first, some facts on the anatomy. The Achilles tendon is the strongest tendon of the human body. It is also one of the longest tendons. The mean length is 15 centimeters and ranging between 11 and 26 centimeters. It originates from 3 separate muscles, the gastrocnemius, the soleus, and the plantaris. This is the triceps surae, and it inserts at the calcaneus. It is involved in the motion of 3 joints, the knee, the ankle, and the subtalar joints. And the calcaneal insertion of the Achilles tendon is not a single point, it has a delta shape. Then the Achilles tendon lacks a synovial sheath. Instead, there is the paratenon, which is a thin layer of fibrovascular tissue. The main blood supply to the mid-portion of the tendon is provided through this paratenon, so not through an artery. And a relatively poor vascularization of this mid-portion might explain the frequent incidence of pathology at this site. Then 65 to 80% of the dry tendon mass is type 1 collagen, and 2% is elastin, which has shock absorbing capacity. Then the etiology of the Achilles tendon pathology. In fact, this still remains unclear and is multifactorial. There are intrinsic factors, extrinsic factors, and genetic factors. Within the intrinsic factors, there is the tendon vascularity, the gastrocnemius soleus dysfunction, gender. More males have Achilles tendon pathologies. Also the age, most frequent in the age of 30 to 39. There is also body weight and height, episcavus, and lateral ankle instability, which can predispose. Then also tendon degeneration. The degenerative tendinopathy is the most common histological finding in spontaneous tendon ruptures. Then we also have extrinsic factors like poor technique, previous injuries, changes in training patterns, footwear, environmental factors such as training on hard, slippery, or slanting surfaces. And then AT injuries occur more frequently in obese persons, with also poor treatment outcomes in this population. And then there are also genetic factors. There are variants within certain genes that have been associated with Achilles tendinopathy, and also changes in the composition of the extracellular matrix of the tendon, which causes changes in the biomechanical properties. Let's now look at some biomechanical aspects of the Achilles tendon and the Achilles tendon disorders. The key biomechanical function of the Achilles tendon is storage and elastic recoil of energy. And during running, jumping, and skipping, the tendon has to withstand a load of up to 12 times body weight. And regarding the biomechanical anatomy of the healthy Achilles tendon, there is a particularity. There is a 90-degree external rotation of tendon fibers at mid-portion, so a spiralization. And this has a biomechanical advantage. It allows for concentration of mechanical stress and absorption of energy during the stance phase of gait, which is then released during push-off. Some biomechanical aspects of a rupture. A rupture typically occurs following rapid eccentric loading of the musculotendinous unit. It also typically occurs in an elongated abnormal tendon fibril. A rupture starts at one particular point and progresses from there, and the initial point can be a mechanically weaker point with reduced collagen content. Ruptures also occur at the narrowest point in the tendon and also in hypovascular areas. And some biomechanical aspects of healing and repair. The general principle of rupture management is approximation of the tendon ends. And the maintenance of the apposition of the tendon ends is important during healing and early movement of the tendon. Unfortunately, elongation occurs with all forms of management. On this image you can see an elongated tendon on the right side. So the tendon length is actually measured between the attachment on the calcaneus, so the bone, until the start of the muscle belly. And in chronic cases there is often a hyperdorsiflexion also with gapping, and gapping is separation of the tendon ends and a symptomatic elongation. And when there is this gapping during loading, this leads to worse outcomes. Some biomechanical aspects of tendinopathy. A tendinopathy can start with a micro-injury with small tears and inadequate healing response. This leads to the formation of a thicker, painful and dysfunctional tendon. Morphological changes in collagen can cause less resistance to mechanical forces. And then calcifications can form in chronic cases. Also, alignment and biomechanical faults have been shown to play a causative role in 2/3 of Achilles tendon problems in athletes. So biomechanical faults such as a significantly increased deviation angle of the subtalar joint, around 80 degrees, compared to healthy. A prominent posterior superior calcaneal tuberosity and lateral process of the calcaneus. A callous foot may be associated with insertional tendinopathy. Eccentric loading exercises are recommended because they lead to a decreased tendon thickness and also a more normalized structure, plus an increased rate of collagen synthesis. Then, as an introduction to the healing and repair mechanisms, I will give you this brief overview of the 5 essential and overlapping processes in the repair mechanism. The first one is the induction phase with infiltration of blood-derived cells like platelets, neutrophils, monocytes, lymphocytes. So this is the initiation of the inflammatory healing phase. Second stage is the production. It's the infiltration with tissue-derived cells for callus production, like macrophages, fibroblasts, endothelial cells, mast cells, and also mediators for repair, like growth factors. Third step is the orchestration step. It is neurovascular ingrowth and also neurovascularization and neoinnervation. Then 4, we have the conduction phase, where there is new tissue ingrowth and also fibril fusion. And then the last phase, number 5, is the modification phase, and there mechanical stimulation will promote tendon repair. And during the healing of the tendon, protection is important. So a key concern is always avoiding a re-rupture. And a re-rupture can occur during 2 mechanisms. Early post-op, there can be uncontrolled loading, and usually there is a rupture at the original rupture site. So we need to protect the tendon, and especially preventing uncontrolled dorsiflexion, so using a boot with wedges. And then a late re-rupture is usually due to a fatigue failure, and the location is mostly proximal to the original rupture site. So this concludes this short introduction. The clinical experts who you will hear in the following sessions will also still add some details about the pathology and etiology of Achilles tendon disorders. I wish you a good continuation of this training and I hope you will enjoy it. Thank you.
Thanks, Francine, for this introduction. I trust we all share the same terminology and a better understanding of the biomechanical aspect of the Achilles tendinopathy. Now, you will hear from the clinical expertise of the French clinician, Dr. Yvan Protois. I am pleased to introduce Dr. Yvan Protois. Dr. Protois is a recognized physician in sport medicine. He has been the doctor of the French national ski team and also the author of a reference book in France on epidemiology and prevention for athlete conditioning. He is actually a consultant in DJO French organization as a known expert in ultrasound imaging, traction, shockwave, and laser therapy. I'm so lonely, broken angel. Dr. Protois with Denis Risséguier, who was at that time our Chattanooga sales manager for France. Here is Dr. Protois demonstrating laser therapy with the chief doctor of one of the largest Chinese hospitals in Beijing. She came with her team to learn on his expertise in using the Chattanooga therapeutic solutions.
Hello everybody. So let's talk about the usefulness of laser therapy, shockwave therapy, and both in the case of Achilles tendinitis. On the right picture, you can see the calf muscle, the superficial calf muscles, going to Achilles tendon. You can see the medial gastrocnemius muscle and the lateral gastrocnemius muscle. On the left picture, you can see the plantaris muscle and the soleus muscle, that is the deep layer of the sural triceps. Here you can see the new vision of tendinopathy developed by Jill Cook. You can have a normal tendon, but you can have also a degenerative portion inside the tendon. You can see that using MRI or ultrasonography, but the patient relate no symptom. And after some activities, you can have a reactive portion all around the degenerative portion, and the reactive portion with inflammatory cells will begin to be painful. And you can have both presentation for the same patient, and it depends over the time. Let's have a look on clinical forms of Achilles tendinopathy. First, you can see the normal view on the top right picture. Achilles tendon is fixed on the posterior and inferior border of the calcaneus, and then continue inside the bone, and then continue with the plantar aponeurosis. The disease can appear because of excess of tension, because of compression against the posterior superior process of the calcaneus, or because repeated friction on the bone. Many forms of disease can occur. Corporal tendinopathy with an oversized tendon, usually with edema and disorganized fibers. Enthesitis at the attachment of the tendon on the inferior aspect of the calcaneus. Bursitis superficial to the tendon, generally by friction with an aggressive shoe. Deep bursitis in some diseases called Haglund disease. In Haglund disease, the prominent posterior-superior aspect of the calcaneus is aggressive in dorsal flexion of the foot. The bone irritates the tendon and creates a deep bursitis and an inflammation of the deep side of the tendon. The green line shows the position of the US probe. The tendon is swallowing and multiple neovessels, normally absent, are present here. Sometimes multiple cracks are visible inside the tendon. In enthesitis, calcifications and enthesophytes are present. Inflammation is also visible. Inflammation is sometimes present. Some bone abnormalities can be visible. Let's look to some studies. First, Tumilty have shown in a randomized controlled trial that adding laser 2 times a week during 4 weeks to eccentric training improves the healing process. Second, Jordak have shown the anti-inflammatory effect of a single application on Achilles tendinitis. Third, Sterjulias, in a protocol design copying that of Tumilty, show also a positive effect on the healing process. Before a laser session, cryotherapy gives a stronger anti-inflammatory effect. The protocol Tumilty were using the Chattanooga HPL device with pulse mode. The session is only 90 seconds long, twice a week. All the energy is delivered on the lesion. Let's talk about our results with shockwave therapy, radial shockwave therapy. In a retrospective study over 6 years, we have used a functional outcome follow-up, and stretching and eccentric exercise were started the first day of treatment and then for 3 months. Results were evaluated on a 10-point pain scale for activity of daily living and sports. We have 4 groups. First one is cured. Second is very good results, more than 80% of pain decreased. Third is more than 60% of pain decrease, good results. And after that, the fourth one is failure. The classic eccentric training is made of 3 phases: stretching during 20 seconds, 3 times, then eccentric training with heel going up to down slowly in 3 seconds. The knee will be flexed for 3 sessions of 10 to 15 repetitions and straight during 3 other sessions. Then the stretching phase is done 1 more time. In our unpublished study, we have treated 58 corporal Achilles tendinopathy with 80 to 86 good to excellent results with 4 to 5 sessions of radial shockwave therapy. We have also treated 11 insertional Achilles tendinopathy with the same results, but 5 to 6 sessions of radial shockwave therapy. So a little bit more. In the literature, reviews are positive concerning shockwave therapy. Results are better when shock waves are associated with eccentric training. In insertional tendinopathy, results without eccentric training are very good at 1 year follow-up and are better when compared to eccentric training. In our last study, we have compared 3 groups: a placebo group, a shockwave group, and a laser group. The follow-up we are using VISA A score, a functional score, and ultrasonography each month during 4 months. The results showed no evolution on US evaluation, but an healing process that was very important using eccentric training alone. The healing process goes faster if we use a tumulty protocol, a very short protocol, and more faster with shockwave. What will happen if we use the laser protocol that is proposed in the manual inside the HPL device? We don't know. In this study, we earned 23 points with eccentric training alone on VISA A score, 31 points with laser in injunction, and 34 points with shockwave in injunction. So, the quality of the realization of eccentric training is an essential element of the result. So we have decided in France to start a multi-sample preliminary study using both laser and shockwave and eccentric training. Here is the protocol. For the Achilles coproreal tendinopathy, we use in the week 1 session of laser and 2 sessions of shockwave. This session of laser will use 3 minutes of interrupted mode on the Achilles tendon, 3 minutes of stochastic mode on nerve trunk, that means sciatic nerve, and 3 minutes of continue mode on calf muscles. From 1 week to another week, the power of the interrupted mode goes up. And for shockwave session, we use 3 modes. First one, 2000 impulses on the Achilles tendon. Then we use a muscular activation mode. Then with the reactor, we use another mode on calf muscles for relaxation. We use a follow-up with VISA Achilles score at the beginning of the study, then in 1 month, just at the end of the treatment, and at 3 months. We don't use ultrasonography for the follow-up because we think that there is no change on a short period of some months on US evaluation. Here you can see the VISA A questionnaire. It takes 5 to 10 minutes to complete it. Generally, the patient needs the help of the therapist to do it correctly. First, we treat each side of the tendon with interrupted mode.
Donc efface. Ils sont plus bas. Ok.
Voilà. C'est là. Là, c'est
After that, we treat the nerve root of sciatic nerve using the stochastic mode.
Un peu trop sur l'extérieur.
And now we use the continued mode on calf muscle.
Glisse un peu plus bas sur le tendon d'Achille en fait, quand tu fais ça. Hein?
Pardon?
Tu glisses un peu plus bas sur le tendon d'Achille quand tu fais
Parce
ça?
que sur le muscle qu'on traite, c'est pas forcément le tendon d'Achille. Il a été traité tout à l'heure.
Ok, alors, on peut arrêter.
First, we treat each side of the tendon.
Voilà, de l'autre côté.
After that, we use a muscular activation on the calf muscle. And then we use muscular activation on the calf muscle.
Recule un peu sur le
So we can ask ourselves which treatment for which pathology. For Achilles corporal tendinitis, you can see here the US sonography pictures with an axial slide on the left and a longitudinal slide on the right, and a small tear inside a big tendon. In this case, we will use the new combination laser and shockwave and eccentric training. In the case of Achilles and tendinitis, you can see on a longitudinal US pictures an antizophyte swallowing of the tendon is thickened, hypoechogenic, and with inflammatory inside on the right picture. Then we will use the same new protocol, but the eccentric training will be a little bit different. In this case, we don't use a step for the eccentric training. We do that directly on the floor. In Haglund disease, then you have a painful tendon at the posterior superior border of the calcaneus, and in dorsal flexion of the foot, you will have a contact with the heel and the tendon, and then it will produce a tendinopathy. You can see that on US sonography pictures and on MRI picture with an edema of the bone and tears inside the Achilles tendon. Even in this case, usually surgical, shockwave therapy can be tried. It was published 5 sessions once a week. The improvement is less important than for corporal tendinopathy, but is present. So before surgery, it is possible to try shockwave therapy.
Thanks a lot to Dr. Protois to share with us his expertise on this valuable information. We have lots more to come, but for now, we'll take a 5-minute break, maybe enjoy a coffee. Please stay connected and we will restart with another guest key opinion leader straight from the break.
Hello, in the next 25 minutes we will show you a pre-recorded interview with Dr. Barfoot where he will give us some insight and understanding in the pathology of an Achilles tendon rupture and also in his treatment approach. Dr. Barfoot is an orthopedic surgeon in Denmark with a specialism in the Achilles tendon, but also in patellofemoral pathologies and shoulder procedures. Dr. Barfoot did a PhD on conservative treatment of Achilles tendon ruptures, for which he was awarded the best PhD of the year 2014 award by the Danish Orthopedic Society. And Dr. Barfoot is currently president of the Danish Sports Medicine Association. I need to mention though that we have to cut some pieces from the original interview for the sake of time, so in order to stay within the time frame. So my apologies if some transitions are not fully optimal or fully smooth. And then also if after this interview presentation you might have questions for Dr. Barfoot, he will be happy to respond to any of your questions, so you can send them to me. So I hope you will find the next 25 minutes interesting and that it will increase your understanding of the pathology of an Achilles tendon rupture and how we can best treat those ruptures. So thank you, Dr. Barfoot, for being with us and giving us the opportunity to discuss with you some of your Achilles tendon rupture cases. So the purpose is that we, by this interview, can educate our audience on how you have treated those patients and why you have chosen for a specific treatment, and then especially regarding their expectations for returning to daily activities, returning to work, returning to sports. So you have selected for us an acute case and a chronic case. Acute means that the patient came to see you right after the injury. Chronic means that the patient waited for several weeks before coming to see you. So first, let's start with our acute case, Mark. Can you tell us a bit more about this specific case and also what makes him a typical Achilles tendon rupture case?
Yeah, Mark is a football player in his end 30s. He is a carpenter during his everyday life and then plays recreational football. And he felt this sudden snap to his Achilles doing a movement which he does every day and which has been done thousands and thousands of times during his life. And felt this sudden snap, a slight pain, and after that he couldn't set off with proper force. He was brought to the ER and we found that he had an Achilles tendon rupture. Mark is a typical case because, let's see if I can make this work. He is in his end 30s, start 40s. And as you see from the graph to the left here, this is where you have the peak of Achilles tendon ruptures. The mean age is 50 years because you have an increasing population of elderly people getting Achilles tendon ruptures, but still people peak at the end 30s. He's also typical because he's male. Every time you have 5 Achilles tendon ruptures, 4 is in a male and 1 is in a female.
And regarding this sudden snap, can this happen in a healthy Achilles tendon, or is there always a kind of an underlying tendinopathy?
That is a really good question, and I'd like to be able to answer that because we do not know. We are doing research within the subject. Most probably there is some kind of an underlying tendinopathy. Several studies doing histopathological investigation of ruptured tendons have shown that you do have degeneration, which looks like what you see in tendinopathy. Mm-hmm. So most probably you have some kind of degeneration of the tendon before it snaps. But it's only 1 out of 5 who feel pain and describe they had tendinopathy symptoms before the rupture. So 4 out of 5 ruptures, they come out of nowhere, snap. Though we see these changes. Mm-hmm. And the question then is, why does it rupture? There's this general debate whether it's due to degeneration or it's due to an excessive stress that just makes the tendon tear. Then there's an idea that it's due to lack of vascularization, and it could be due to a slow bacterial infection. You brush your teeth, you get bacteria into your blood, and this bacteria can then sit in different tissue and it make a slow infection. And then what I think is probably the best explanatory model is that you create your tendons when you are in the adolescence. This graph, it shows samples from cadavers, so from dead people, and it shows the content of carbon-14 in the tendon. And you don't have to understand the graph, but the graph shows that the content of carbon built into your tendon was put there at the age of 16 to 20 years and hasn't been renewed since. So it means that the tendon tissue I'm walking with, it was put down 25 years ago and it hasn't been renewed. And if it is so, you will get small ruptures in the tendon, you will get an increasing wear of the tendon, and that might provoke it to tear.
And for your diagnosis, which imaging modalities do you use?
Oh yeah, I like that question. It is so that I'm a very strong believer in clinical diagnosis of acute Achilles tendon rupture. I think it is directly wrong to use imaging in your standard diagnosis of acute Achilles tendon rupture. It's a clinical diagnosis. It's based on a patient history with a snap, a positive calf squeeze test, so you squeeze the calf and you do not get a response of the foot, and Thompson's test, where you flex the knees and you see one foot is hanging down in this angle of dangle, as it's called. The reason that you shouldn't use imaging is that ultrasound and MRI can be false negative, and I have seen far too many cases of patients who have had imaging and you have said, or the doctors have then said that you do not have a full rupture, you have a partial rupture, and then treated them falsely. It is so that on this picture you have the Achilles tendon to the left, you have the calf muscle to the right, and here you have the plantaris tendon. In this case, the plantaris tendon is lying outside the Achilles, but in around 50% of the cases, it's lying embedded in the tendon. And when you operate on them, you can see this. Like here, we have opened a chronic rupture, and you see the plantaris embedded in the rupture site. And if you ultrasound or MRI scan this, you will see intact fibers due to the plantaris tendon. Another reason that you can get false positive responses is that a rupture doesn't happen like this. A rupture takes place like this. So all fibers in the tendon rupture, but not at the same place. They don't rupture like this. They rupture, some rupture distally, some rupture proximally, and in that way, they just pull a bit, but you will almost always have overlapping fibers at the place of rupture. And that can as well be misdiagnosed as a partial rupture. Okay. So the diagnosis is clinical.
Okay. So, and for such an acute case of Achilles tendon rupture, what is actually the most critical factor that requires your attention?
That's a good question as well. I believe that the most important thing is to immobilize the foot in maximal echinus position. If I had a rupture, my foot should be put in maximal echinus position right away, and then it should be kept there until I was able to scan it and evaluate how far the tendons had pulled from each other. So in the acute setting, I think it's putting the foot in maximal echinus position, not walking on it. If you then have a patient who has been walking on the foot coming into the ER after hours or several days, then I would say the important thing is to evaluate if you have a good overlap or you have pulled the tendon stump from each other, and in that case might need surgery.
Yeah. So yeah, this brings us to the next question. For this acute case, how did you decide on going for either surgical or non-surgical treatment?
First, a little about the pros and the cons of surgical and non-surgical treatment. To summarize it shortly, I would say that non-surgical treatment yields a satisfactory result for many without exposing the patient to the risk of surgery. So most patients, they get a fully acceptable result from non-surgical treatment. And when you look into those controlled cohorts, it's not possible to show important differences between those surgically treated and those non-surgically treated. So in my opinion, the non-surgical treatment is the standard go-to treatment. The pros for surgical treatment is that you do get a lower risk of re-rupture. And there's no doubt about that in my mind. You have a 2 to 4% risk of re-rupture if you treat people surgically, and you have 10 to 12% risk of re-rupture if you treat non-surgically. I know there are large cohorts that have shown lower results, lower re-rupture results among non-surgically treated patients, but they do not have good follow-up on their patients, and I don't think they are to be believed. We have, and all studies with a good follow-up have not been able to show re-rupture risks significantly below 10% if treated non-surgically. And then finally, when you treat surgically, you might be able to control the length of the tendon better. So for this case, let's see what my next slide was. For this case, we used our algorithm. So we looked at the morphology of the tendon and the displacement of the tendon stumps. If we look first here to the right, we looked at morphology of the rupture site. Did we have overlap of fibers? Or was it pulled like this and you had good overlap of fibers, or was it one of the seldom rare cases where you actually had torn the tendon stumps apart and you did not have overlap? And then we looked at the quality of tendon substance. So where you have this thinning of the tendon, does it look like you have a proper overlap, or is it more thinned out? Then nextly, we looked at the displacement of the tendon fibers. And this is difficult because if you pull like a bundle of macaroni apart, it's difficult to say where's the end, where's the stump, what does the stump end. So instead we look at displacement of the muscle belly and the bone. So the actual elongation of the working muscle. And in this case, there was too much elongation for us to be accepted, and therefore we chose to do surgery on him. Okay. This algorithm is being tested at the moment. We have done a range of studies leading up to it. We have not shown yet that it works, but we hope it does.
Mm-hmm. Okay, and can you also tell us a bit more about the immobilization protocol, the post-op immobilization you used for this patient?
I believe it's extremely important to immobilize the foot the first couple of weeks after rupture. And my experience tells me that the patients are not to be trusted in this period. Some are very rigid and do exactly as they're told, but many they don't really behave, and they take off the boot when they go to bed, and then they have to go to the toilet and might walk on the foot and so on. So we immobilize the foot in a circular plastic cast for the first 3 weeks with the foot in maximal Achilles position. After that, we take an air cast walker with wedges in the boot and use that for the next 6 weeks with partial weight bearing. And following that, we have 3 months of rehab where we recommend a heel lift of 1 centimeter or use of a running shoe, because you have the same heel lift built into a running shoe. When you use the orthosis, it's really important to consider the orthosis, because the choice of orthosis matters. This is a study by Ellison et al., who showed that here, if you look at the A, this is a neutral position. This is an Achilles cast. Here you have a hinged orthosis, and here you have an orthosis with wedges. And if you look at the angle between the blue line here and the tibia, you see that you do not have much difference between A and D, whereas in B and C, you have much better plantar flexion of the ankle joint. We have shown the same with different wedges. And you see here that if you use wedges with a plateau, you have the same problem, that you do not relieve the tension of the Achilles. So you have to use the wedges without a plateau in order to get a proper plantar flexion of the ankle joint.
Mm-hmm. Okay. And how important is rehab for an acute Achilles tendon rupture? And are there any key elements for an optimal rehab?
Yes, thank you. It is so that when discussing how to optimize operative or non-operative management, when you come around the world, you will hear that accelerated rehabilitation is considered the key. I believe that is wrong. I think the most important thing is to get an early intervention. You have to put the foot in Achilles before the hematoma forms. Mm-hmm. You have to have a correct immobilization, a structured setup around the patient, and you have to select the right patients for non-operative treatment. 3 large studies have investigated the matter, and they have all shown that it does not work with accelerated rehabilitation. Based on that, we have chosen to alter our algorithms. Muscle tissue heal quickly. Within 4 to 6 weeks, muscle tissue heal. Tendon tissue heal extremely slowly. It takes half a year for a tendon to heal. And if you put too much stress on the tendon in the beginning, it probably elongates. And what you do not want, it's an elongated tendon, because then the muscle is at the wrong working length. So we have changed our way of looking at it to being focused on getting a tendon in the right length, and then the muscle will follow. So we have been careful with the accelerated rehabilitation. Mm-hmm. Looking at the rupture, you see the black part, it's tendon fibers, and the white part here, it's hematoma. This hematoma forms within the tendon stumps. And if there's too much hematoma, it's pushing the tendon stumps apart. Therefore, we need this early intervention, putting the foot in Achilles to avoid a big hematoma. Another problem is that 80% of patients, they have no pain. They're able to walk right after the rupture. So they are not afraid, and they don't consider it an important injury. And they are to be treated and cared for and informed that it is an important injury. Mm-hmm. And that's where your orthosis is paramount, because if the orthosis is too easy to put on, put off, and if the foot is too loose in the orthosis, they get careless. It's important to fix the foot and let them know that they have a problem. Mm-hmm. And I think that the non-operative management is more demanding than the operative, because when you operate on people, they know they have a problem. Yeah. Yeah. So this is our setup. We put them in Achilles plaster. We see them within 1 to 4 days, decide on whether to operate or not, and then we follow them closely.
Okay, and then another question we have is what does an Achilles tendon rupture mean for the proprioception and neuromuscular control of the patient?
And that's extremely interesting as well. We thought that when you get an elongation of the tendon, you will get a muscle at a wrong working length, and that will affect your proprioception. We investigated 60 patients 4.5 years after rupture. We found they had 1.7 centimeter elongation. They had an increased Achilles tendon resting angle, which is also due to the elongation. They had decreased leg circumference, and they had increased dorsiflexion. So they ought to have a worse proprioception. We looked at the stiffness and found that they had a reduced stiffness of their tissue, which means that they can refer less force, and that the nerves in the tendons should be less able to know where the foot is positioned. Again, it should affect the proprioception. Then we did a range of different tests. And you have equipment to do this as well, foot pressure sway analysis. This is an example where at the left you have a normal sway and at the right you have an increased sway. So that was what we expected to see. But in reality, we found that there was absolutely no difference between the uninjured and the injured limb. So they had the same sway in the injured leg compared to the uninjured leg. So it didn't seem like they had a worse proprioception. We then investigated foot pressure mapping because we expected that they would have a different push-off and a different use of the foot due to the elongated tendon. But we did not see any differences except from a slightly slower heel raise. So our conclusion was that we were not able to find any differences in proprioception.
Okay. Then you already mentioned the risk for re-rupture being lower in the surgical treatment. What is your recommendation now to a patient to avoid a re-rupture?
That is another good question, Francine. It is so that most re-ruptures, they happen in the period after they come out of the orthosis. So 2 to 4 months after the primary rupture. If they're surgically treated, it's 2 to 4%. If they're non-surgically treated, it's 6 to 12%, depending on which studies you look at. So to avoid re-rupture, we ought to operate on them all. But then, of course, we provoke other risks by operating on them, and that's the balance we have to find. My recommendation to the patient is to be careful, and we always give them the orthosis home after we take it off, and recommend them to use it in strengthened situations. So if they are to walk in the woods, if they are to do hard physical labor and stuff like that, where they put an extra load on the tendon, we recommend them to put on the boot. And then for the first 1 to 2 months after they have been taken out of the boot. And then this heel lift of 1 centimeter we recommend as well. That being said, some non-operatively treated cases, they simply haven't healed. And when you open them afterwards during surgery, you see that there was no risk, no chance that they would have healed. So they should have been operated on from the beginning. And those are the ones we try to find with the algorithm I showed before.
Okay, so and now Mark, how did he recover finally, and was he able then to return to his previous level of activity, to his work, to his soccer sports?
Yes, Mark, he got back to his work after 3 to 4 months, and back to sport, where he started playing a little bit after 9 months and participating in matches and so after 12 months. But it was a really hard year for him. And a lot of these patients, they get a psychological push from the injury. It is so, yeah, I had some here on re-rupture, we can get back to that. It is so that before rupture, most people have no problems. After half a year, they are still doing rather badly. After 1 year, they're doing better. And after 2 years, they're doing even better, but they're still not anyway near what they were before in average. So that 30% return to sport after 1 year and 40% after 2 years to the same sport. But still it means that 60% they do not go back to the same sport. Looking at how they rate themselves, you see that after 4.5 years, they still rate themselves 20% lower than they did before. So they do not regain full function of the leg. And when we investigate how much work they can do, they have 40% reduced work on the injured leg compared to the healthy leg in average. So we're not able to recreate the tendon muscle complex as it was before. Yeah.
Do you still want to return to those previous slides on the photos on the re-injury?
Yes, let's do that. You see, it's this thing about the tendon not healing. This was a chronic re-rupture where the patient had walked on the foot, and we had tried to treat it non-operatively. And then again, it had taken several weeks before he came in. And when I opened the guy, it looked like this. So you see, you have a structure which looks like an intact tendon. And you know, you get, even though I see it often, each time I get a little, did I make a mistake on this one? Then I pull it, and you see, by pulling it, it's too thin, it's too loose, there's something wrong here. And then when I open it, you see, it's just the parathenium. The parathenium has a very good capability of healing the tendon. And you see the parathenium has tried to heal the tendon, but you have a stump lying here, and you have a stump lying there, and this is just old hematoma. After taking away the hematoma, you see it more clearly, and you have the transversing plantaris tendon here. And this would not heal. And after pulling it back together and suturing, it heals good. So this is a case where it should have been operated on from the beginning, and hopefully we will show that by using the algorithm I showed earlier, we'll be able to find these cases and operate on them. And then we can leave those who do not benefit from surgery to the non-surgical treatment.
Okay, so this acute case was already very interesting. We have some time left to quickly discuss also the chronic case. So, in fact, when such a chronic case comes to see you, so weeks after the injury, what is then your key concern for such a chronic case?
Yes. The typical chronic case is a patient, I would say, around 60, who has had problems with his or her Achilles for a longer period of time and might have had some small injuries or tears to the tendon, has gone to his or her general practitioner and has been misdiagnosed as being a tendinopathy. And then they have been walking on the foot for weeks, months, and then they come in without a proper push-off. And when you feel there is hardly any Achilles tendon, you have a real gap in the tendon. These patients are difficult because they are very different from the acute cases. They won't heal in the proper way. So either you do surgery on them, where you open up and you resect all the bad tissue, and then you see what's left. So it's you never know what you come out with when you walk into surgery, and you have to have a rather large toolbox to be able to work on that, because sometimes you can pull the tendon stumps back together, other times you have to do tendon transfers and so forth. And it's a risky group of patients because they usually have some comorbidity. They might have diabetes or other stuff that makes it difficult for them to heal. And when you do the reconstruction, you pull the tissue together and it affects the tissue, and you have an increased risk of infection. And when you get infection, you take half a year or 1 year of their life, because then they have to go to these controls and we have to get rid of the infection. And it's it's a strenuous process for the patient. So you have to really consider how to treat them. And it's based on of course their comorbidity, how healthy they are, and then that demands. because many people can get a perfectly well-functioning life without function of their Achilles. They can have a proper walk without a limp, and they can do what they want. Problem comes if they want to be able to run, if they want to be able to play tennis and stuff like that. It's difficult. And then some people, they do get a limp after if their Achilles doesn't work, and they should be reconstructed. But it's a difficult group because you have to adjust their expectations, their health, and balance that with the risk of surgery before you go into surgery.
Yeah, I see.
Then I'll just like to wish you a nice day and good continued training.
Yeah, I wish you the same. So thank you very much again. And if the audience afterwards has questions, I will come to you with the questions, and then we will get the answers to the people.
Absolutely. All the best.
I would like to thank Dr. Barford for his participation in this training. It's really a unique opportunity to learn from such a global recognized expert. It's all very valuable information to strengthen our expertise on this topic. Now, Pipiton, our DJO International Clinical Sport Specialist, will present an overview of the solutions offered by DJO around Achilles tendinopathy.
The first thing I'd like to say is, please do not presume that therapists know what interventions are the best and what products are available to provide the best outcomes for their patients. With the resources we have, like our research database on IDJO, you can be the expert that the therapist feels they can trust for advice. Build empathy with the therapist by asking what issues they have when treating tendinopathies, or how do they typically treat an Achilles tendon post-rupture. You cannot provide a solution without knowing whether the therapist has a problem. Gregory Hess in 2020 published a paper on the etiology and prevalence of Achilles ruptures. These are typically observed in 40 to 60-year-old men. The male to female injury rates range between 2-to-1 to 12-to-1. Aging results in a predisposition of chronic degeneration of the tendon. Blood flow decreases and stiffness increases, thus reducing the tendon's ability to withstand stress. Avoidance of degenerative changes within the tendon is the primary method to prevent rupture. So, when an at-risk patient presents to the therapist clinic, what interventions can we offer the therapist? The tendon will present either as a non-inflammatory tendinosis or a chronic tendinopathy. Now, if it's the latter, we need to allow it to settle by reducing the stresses being placed on it. In our ProCare range, we have Thule heel cups and also silicone heel cups. These are designed to raise the heel, thus reducing the stretch placed on the tendon. The design and materials used also help to reduce the amount of stressors being transmitted to the tendon during weight-bearing activities. Inflammation is reduced by the body's lymphatic system that helps to drain the unwanted exudate. To assist in facilitating this, compression of the tendon is beneficial. Our Aircast Air heel brace has air pockets that actively compress the tendon during the gait cycle. These can be worn in conjunction with our heel cups if warranted. Compression can also be combined with cold, which will provide an analgesic effect. For this, we have the Aircast CryoCuff range. Now, many therapists are under the misapprehension that cold also acts as an anti-inflammatory. this has been proven not to be the case. So if a patient presents with pain and has no inflammation, then using our cold pack range may be enough to provide an analgesic effect. In an acute presentation, it's likely that we will have an inflammatory response, as this is an essential part of the healing process. Inflammation starts in the first few hours of onset, reaching its maximum around about day 3, after which it gradually subsides over the next 3 weeks. We can provide interventions that will optimize this natural process and expedite healing. And this is where our photobiomodulation therapies like low-level laser and high-intensity laser therapies are proven beneficial interventions, as indeed is therapeutic ultrasound. The advantage of high-intensity laser over low-level laser therapy, or indeed ultrasound, is the quicker response times and the fewer clinic visits required. Occasionally, due to the patient continually aggravating the tendon, or has been recently shown, the influence of macrophages, the healing process can stall and the patient presents with a chronic presentation. At this juncture, we need to restart the normal healing process by introducing pro-inflammatory modalities like radial pressure wave or focus shock wave. Now, after 3 to 4 sessions of one of these interventions, the normal inflammatory process should have restarted, and we can then commence the acute management protocol that we've just outlined. Now, it should be stated that with the use of pro-inflammatory interventions like shockwave, these can be combined with inflammatory optimizers like our photobiomodulation therapies or ultrasound. And current research is starting to show the significant benefits of this combination of therapies. Finally, for therapists fixed on using exercise therapy, you're going to be preaching to deaf ears. Therefore, you must point to the research studies showing that combining electrophysical agents with exercise provides significantly better outcomes than just using exercise prescription alone. Now, should a patient present with a new Achilles rupture, then we need to protect it from further trauma, address pain, and keep inflammation to a minimum. To this end, therapists should be prescribing cold and compression, as well as placing the patient in an air cast walker. The patient should be referred to an orthopedic specialist to determine whether a surgical or conservative treatment management would best suit the patient. But while waiting for an appointment, the therapist can begin to influence the healing process by the intervention of photobiomodulation therapies or indeed therapeutic ultrasound. If there are any concerns of the patient developing a DVT, then they should be encouraged to use our VenaFlow system. Now, if one of these systems is not available, then the capillarization program on our Chattanooga 4-channel NMES range, combined with a compression stocking, has been shown in the literature to be at least as effective as using one of our intermittent compression devices. And it's also worth stating that either the VenaFlow or NMES can be used in combination with our aircast cryocuff. The post-op and conservative protocols are quite similar. It's the time to full recovery that changes, and the choice is usually dictated by the demands of the patient. Protection and pain relief remain a primary intervention. Of note is that if plaster of Paris is used instead of one of our aircast walkers, rehabilitation is delayed by at least 4 weeks. Continued passive motion, CPM, has been shown to increase DNA and protein synthesis at the repair site, as well as influence collagen alignment. In conservative treatment, this will commence about weeks 3 to 4 when the tissue is starting to knit back together. But CPM can be started earlier with a surgical intervention. And once again, if the risks of developing a DVT warrant it, then our venoflow system or NMES can be used in the early stages of the rehab process. NMES strengthening programs can be commenced once the patient begins partially weight bearing. However, on those muscles not directly affected, but still need to be maintained for good function, for example, the quadriceps, hamstrings, abductors, adductors, gluteal muscles, then NMES can be started as soon as tolerated by the patient. The influences of photobiomodulation therapy and therapeutic ultrasound are now much better understood at a molecular level. So once dressings have been removed, these interventions should be introduced to enhance the healing process. And finally, as we progress through the rehabilitation process, we can gradually reduce our use of photobiomodulation therapies and ultrasound while increasing the use of NMES, remembering to combine it with functional activities and exercise. Thank you.
Thanks, Cliff. We have now a better picture of all the therapeutic solutions that the therapist can find within DJO. They are all based on clinical evidence, but how to properly manage clinical evidence? Here is the next topic that Francine will now introduce.
Hello, I'm Francine, and in the next 15 minutes I will introduce you to the concept of evidence-based solution selling. And why? Well, we have now in our database on IDJO a huge amount of studies already, close to 2,000. So the challenge is, how can we now best make use of all those clinical data? Well, evidence-based solution selling is kind of a method, a structured approach that can guide you when you want to present a clinical study in a conversation with your healthcare practitioner. So it is actually developed to meet the expectation of healthcare providers that practice evidence-based medicine. So first of all, what is evidence-based medicine? Sackett et al. Published a definition in 1996 in the British Medicine Journal, saying that it is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. So simply stated, it means that the healthcare professional integrates the best available clinical evidence from research with his own clinical expertise. And why are healthcare professionals nowadays practicing this evidence-based medicine? Well, regulators now require medical schools to teach competency in evidence-based medicine. And medical students learn to critically appraise clinical data and to look for validity, for bias, for statistical significance, clinical relevance, and as a consequence, this influences physicians' expectations of sales representatives. Evidence-based solution selling helps the sales rep to meet this physician expectation. It helps to speak the correct language when presenting clinical data. Research has revealed that evidence-based medicine holds the strongest customer buying influence. Also, a survey in the USA has shown that over 90% of physicians want representatives to make more use of clinical studies and evidence-based medicine in their conversations. So the clinical selling skills should be based on understanding of the principles of evidence-based medicine. This slide shows the process of evidence-based medicine. It is a cycle consisting of 5 important steps And then we will also show the corresponding steps in evidence-based solution selling. So healthcare providers that practice evidence-based medicine go through a 5-step process to provide the best treatment available to their patients. The first step is formulating a clinical question. And then, based on the clinical question, the healthcare provider will research the best available data. In step 3, he or she will then critically appraise the data to determine the validity, the significance, the relevance, the applicability to the practice or to their patient. Then in step 4, upon review of the most valid and significant data, the healthcare provider makes a treatment selection based on the relevance of the clinical data for his patient and his practice, and he will implement the selected solution. And then in a last step, he will evaluate the outcomes. Was the application of the new treatment procedure effective? Should this new clinical practice procedure continue to be included in his day-to-day applications? Could any of the 5 steps in this process improve the next time a question is asked? And then in evidence-based solution selling, we will follow the corresponding steps when presenting clinical data. So we will also start with understanding the clinical question that we can answer with our clinical data. In the second step, we will look for clinical evidence on databases like PubMed, Cochrane Library of Systematic Reviews. Our third step will also be critically appraising the evidence, so looking at the statistical significance, the validity of the data, and therefore it's important to understand how to read a clinical study. Step 4 will be showing the clinical relevance of the study data to the HCP's practice and his patients. So will the results help the HCP in caring for his or her patients, and how the information and our product can impact their practice. And then the last step will be summarizing the agreements we made during the previous steps in the conversation to get his commitment and to act on next steps to advance the sales or the brand choice. In this 5-step process, there are in fact 3 very important items. It's the items the HCPs are looking for when they consider the clinical data. So the first is the validity. So this is about an appropriate study design in order to decrease the likelihood of bias. Then the HCP will be interested to learn more about the statistical significance of the data to be sure the study findings were due to the study intervention and not to chance. And then last important item is the clinical relevance. So how the information applies to his practice and his or her patient population. Because many representatives present clinical data starting with the results first. For instance, we want to say, Doctor, look, I have an interesting new publication showing that 3 weekly sessions of RPW treatment is effective for improving symptoms in Achilles tendinopathy. But it has been shown that only after a healthcare practitioner believes that the data we are showing are valid, then they want to hear about the statistical significance or the results of a study. And once they understand the data are valid and significant, they want to know how the data is clinically relevant to their practice and how it will help him to achieve his practice goals. We will now look a bit closer into each of the 5 steps of evidence-based solution selling, starting with step 1, the clinical question. For formulating a good clinical question, we can use the so-called PICO principle, where the P stands for patient, the I for intervention, the C for comparison, and the O for outcome. Those 4 aspects should be incorporated in the clinical question. So first of all, the patient problem or patient profile. This includes, of course, the primary disease and other relevant characteristics such as coexisting conditions, demographics like age, gender, family history, lifestyle, dietary or exercise habits. Then the intervention. Which main intervention are you considering for the patient? Is it prescribing a drug, performing surgery, the use of an electrophysical agent? Then we have the comparison. What is the main alternative to compare with the intervention? For instance, compare with standard care, compare with placebo treatment, compare with no treatment, compare surgical versus non-surgical treatment. And then last we have the outcome. So which aspects do we want to improve or affect with our treatment, and how are they assessed or measured? For instance, this can be relieving pain, reducing the number of adverse events, improving function, improving healing rate. And there are primary versus secondary outcomes. So as an example, in Achilles tendon rupture, a primary outcome could be the re-rupture rate, and a secondary outcome can be return to sports. A simple example of how applying PICO for formulating a clinical question can be the following. So a patient with lateral epicondylitis, female, professional tennis player, the intervention photobiomodulation therapy or laser therapy. Then the comparison can be placebo laser therapy, and the outcome, pain on a VAS scale and grip strength. So the clinical question we can make here is photobiomodulation therapy more effective than placebo for improving pain and grip strength in female tennis players? Next we have step 2, finding research evidence. So we will look for studies that can answer the clinical question. We will search on keywords from the clinical question. We will try to find, of course, the best evidence. Therefore, we will select appropriate resources. We look for articles from quality journals, and they can be found in databases such as PubMed, Google Scholar. PubMed is a huge global database of scientific publications. It includes millions of references to articles from medicine, nursing, basic science, biomedical fields, and the coverage is from the 1940s to the present, and it includes over 5,600 journals from around the world in many languages. And then if we want to look for systematic reviews, we have the Cochrane Library, which is a very prestigious database for systematic reviews. When we are critically appraising the evidence, it is important to know that not all evidence is created equal, and there is a hierarchy in the quality of the evidence. In order to select the best evidence, you can use this pyramid. As you move up the pyramid, the potential for bias decreases, so the publication quality increases, and also the number of published studies decreases as you go up. On the top of this pyramid, we will find the meta-analysis and the systematic review. This is considered the highest level of evidence. Because we are limited in time, I will quickly go through some key aspects of each of those study designs. So at the top of the pyramid, we have the systematic review and meta-analysis. A systematic review is a synthesis of primary research studies, and it uses a standardized, rigorous methodology for selecting and analyzing the studies. A systematic review can or cannot include a meta-analysis. And the meta-analysis is a statistical technique for quantitatively combining the results of multiple smaller studies that address the same clinical question and measure the same outcome. And the quality of a meta-analysis is dependent upon the quality of the research of the included studies. Within the experimental studies, the randomized controlled trial is the highest level of research. In a randomized controlled trial, the subjects are randomly allocated to receive or not receive an intervention. So they are allocated to either the treatment group or intervention or control group, and this allocation happens at random. There is in a randomized controlled trial the concept of blinding, but this will be explained in a later slide. So then on the next level we have the cohort studies. A cohort study analyzes data from groups or cohorts who have or have not had exposure to the factor affecting the outcome. There is a typical example of smokers versus non-smokers for the outcome lung cancer, but in our field we could, for instance, compare a group of skiers wearing a prophylactic knee ligament brace and a group not wearing a brace for the outcome knee ligament injuries. And then a cohort study can be prospective when the cohorts are followed forward in time, or retrospective when they are looking back in time, so using data from medical records or a claims database. Then next we have the case control studies. So here a group of patients with the disease, the cases, are compared with another group of subjects who do not have the disease, the controls. For instance, a group of Achilles tendinopathy patients could be compared with a group of subjects that have a healthy Achilles tendon in order to try and distinguish factors that contribute to the development of tendinopathy. Then we have the case series and case reports. A case report is a detailed descriptive report of one patient, and when we are describing a series of patients, we are dealing with a case series. A case report or case series has no control group. Then at the bottom of the pyramid we have the animal and laboratory studies. It's about experiments using animals or biological specimens, and this is usually done to test how safe and effective new treatments are before they are tested in humans. So in this step 3, critically appraising the evidence, there are two key items which are validity and significance. The validity is the extent to which bias is or is not introduced to the clinical data. The lower the bias, the higher the validity of the data. There are some key evidence-based medicine principles that allow to evaluate the validity. They are mentioned in the blue squares that will follow now. I cannot go into detail of each of the aspects. We can do this in a later training. So there is the randomization, which I explained earlier. There are also the baseline characteristics that should be similar for all subjects. There is a principle of blinding. This means that people involved in the study do not know which treatments were given to which patients. And there are several levels. There is single blinded. This means only the patients don't know whether they get or get not a treatment. Then there are double blinded studies where next to the patients also the researchers don't know. And then there are the triple blinded studies where next to patients and researchers also the statisticians don't know who was in the active group and who was in the control group. Then follow-up is also important because the study should begin and end with the same number of patients in each group, and patients lost to the study, they are called dropouts, which can happen because, for instance, for an adverse event, they must be accounted for in the final data analysis, otherwise the conclusions are not valid. And the term intention to treat means that every patient that has been enrolled in the study is also included in the final analysis, whether or not he has completed the follow-up. Then another aspect is the conflict of interest, and then also we have the journal. The higher the quality of the journal, the more valid the study will be. Then looking at the statistical significance, this is important because it demonstrates that the results of the study did not happen by chance and that the results are reproducible. So this will provide the healthcare practitioner confidence in the data you are presenting. There are a lot of statistical terms that we need to understand. I will not go into detail of all those concepts now. This would lead us too far, but some of them will be covered in another training. Of course, we are not statisticians, but we need to have a basic understanding of some concepts in order to be able to discuss statistics of clinical data with a healthcare practitioner. So there are terms like confidence interval, effect size, absolute and relative risk reduction, number needed to treat. There are terms like standard deviation, the p-value, the mean, the odds, the median, well, a lot of terms, but too much to tackle all now. So in step 4, once an HCP understands that the data you are presenting are valid and statistically significant, we will then demonstrate how this data may be clinically relevant to their practice. And we can do this by discussing appropriate subgroup analysis, discussing also the baseline characteristics of the study population, because when looking closer to the subgroups and the baseline characteristics, we can discuss whether there are similarities with his patient population. It's also interesting to leverage from specific quotes from the authors, from the results or discussion sections of the clinical study. And also here for subgroup analysis, there are concepts and terms we will need to understand, but we will not go into the detail of these terms now because our time is limited. This can also be covered in another training. But should you be interested already to learn some basics of subgroup analysis and the terms like ANOVA, post hoc, then you can watch the YouTube film, of which the link is here mentioned on this slide. And then our step 5, which we like very much to achieve, is that the HCP finally prescribes our treatment or buys our product, and he is likely to incorporate our product or solution into his practice when he believes the data we presented are valid and statistically significant, when the data are clinically relevant, and when we have been able to answer the HCP's clinical question with our data. So again, it is important to use the evidence-based medicine language in our conversation. So this brings us to the end of this short introduction to evidence-based medicine and evidence-based solution selling. In the breakout sessions later in this training, I will give an example for applying this method on a real clinical study. In the bracing and supports group, I will use a study on walker immobilization in conservative treatment of Achilles tendon rupture. And in the recovery science group, I will use a study on RPW treatment for Achilles tendinopathy. So see you soon again.
I would like to thank all of the speakers involved in the preparation of this session. It's time now for the Q&A. So we have a few questions for the doctors, for Dr. Protois and Dr. Barford. Dr. Protois and Dr. Barford are not live in this call, but definitely we will read the question and we will address the question, and the answer will be provided to all of you guys, or all of the attendees. So the first question for Dr. Protois was, has eccentric training been replaced by isometric and concentric training? The second question to Dr. Protois was, why do you use an interrupted emission mode compared to a continuous mode? Then we have a question for Dr. Barford. So Dr. Barford, is conservative management also the therapy of choice for top sports athletes? Is there any orthosis to use after rehabilitation period to prevent re-rupture or make the patient feel more secure about activities? Dr. Barford, will you ever consider using laser therapy in theater directly on the repair tendon prior to closing? A question from our team in Sweden. Dr. Barford, we are doing a trial here in Gothenburg by introducing an MES training early in the rehab process, 11th day and forward. So have you evaluating this method on Achilles tendon rupture? So here are all of the questions we have for the healthcare professional. There is one question for Francine. Francine, this is a very important topic on the evidence-based selling. It would be appreciated if you could be sent the PowerPoint of the evidence-based selling solution.
Of course. And also we will further dig into this concept in future trainings. We still have to think how we will organize it to bring it in a digestible and structured way in future trainings. We may involve the help of an external partner. We're still looking into the matter, but yeah, sure, I will share this presentation, which is an introduction, and then we will keep you posted on how we will further approach this important topic in future trainings.
Yeah, if I can jump in, Blair, that's I agree totally. This is one of our main differentiators between us and our competitors. I know we're talking about competitor analysis later, but we need to set ourselves apart by demonstrating that we can provide evidence-based practice. So yeah, really important. I'm glad that Kim brought that up. And if I may, I may be able to throw some light on the question with regard to eccentric training and has it been replaced. The short answer is no. But in the early days of Alfredson's work, where he started to introduce eccentric training for tendinopathy loads, they had good results. So in early studies, like back in 1998, Romper did a study where he compared radial pressure wave to eccentric training and found that shockwave came out slightly better. And in a subsequent study, they looked at radial pressure wave compared to eccentric exercise compared to combining with eccentric exercise, and found they got significantly better results. So obviously, you know, as we learned from Francine, then subsequent authors and researchers sort of jumped on that bandwagon of comparing eccentric exercise to everything. Now, what we've learned since, and there's Magnuson talks about heavy concentric loads, for example. So there's debate in the literature about whether heavy concentric loads are better than eccentric loads, etc. Now, Peter Maliaris, somebody, a researcher we work with in Australia, and a very proficient researcher on tendinopathy management, talks about the need for slow, heavy loads. So if you've got a heavy load and you're doing it slowly, you've obviously got an eccentric component, which is important part of strength gains. And bear in mind that we're trying to influence the healing process. So as we learned from Francine earlier, we have a high proportion of type 1 collagen fibers within the tendon, but when we get an injury, they're replaced with type 3 collagen fibers. Now, the importance of exercise is to replace those type 3 with type 1, and that's what we do with resistance training. So having this heavy, slow load, we get an eccentric component, but we don't always just lower ourselves down on a heel. Obviously, you know, we heel raise, we jump, we hop, and all these things. So having that concentric component is important. So my preference would be to work with this heavy, slow load component. Now, there's no research as yet comparing or combining radial pressure wave, or indeed focus shock wave, with this type of loading, because as I said, they've all sort of, all the authors have jumped on this eccentric loading due to the early stuff. So it'd be interesting to see what sort of happens later on. But something else that you could bring to the attention of your clinicians is that once we've got that heavy, slow load and we've got a tendon repair, then we have to think of the demands of the patient, and we have to think about frequency and rate of load. Now, why is rate of load important? If you were to compare something like doing a heavy squat and a counter jump is where you sort of lower yourself and spring off the floor. If you look at the loads placed on the patella tendon, they equate to about 6 times body weight. But if you look at the rate of, about 8 times body weight, just claim to me. But if you compare the rate of load with a counter jump is 50 times more than it is with a squat. So just having load is not the be all and end all. You've got to have rate and frequency of load included in your rehab. And these are the type of information that we at Chattanooga, if we know this, that sets us apart from our competitors. So there we are.
Yeah, thank you, Cliff. I just have a quick answer on the Dr. Protois question about the emission mode for the laser therapy. Dr. Protois was using or copying, I would say, the humidity protocols. On the humidity protocol was a pulse 100 Hertz emission mode. So he was doing the same to stick with what was published, and but there is no evidence today that using a more continuous mode would be better or less efficient. Maybe you have a word on that. Cliff, any comment on this?
Yeah, look, yeah, I agree. You know, they're sticking to protocol, and you've got to you've got to hang your hat on thing. But bearing what I thought when he was discussing that was that he was still in that acute stage where we've got inflammation, and whilst we know with continuous mode we get biostimulation, but with high power laser we can also generate heat, which is an unwanted side effect, really. So I certainly in clinic I would use the pulse protocol in that presentation.
Okay, thank you. So the replay of the webinar will be emailed out within 3 working days, so that can be shared within your team. We look out for post-webinar survey after the breakout session today, so please complete it to help us produce more on better webinars. The only way we can improve our format is to hear from you. So you now have a kind of a 5-minute break before you should join your business unit breakout session, so or bracing on the Walker or Chattanooga on the RPW2. So the session will start at 11 sharp, and you will have received your reminder email with your link to that session a short time ago. Thank you.